decision. So first and foremost, when you're in clinical practice, a lot of decisions are made based on your philosophy, your personal experience, what your comfort zone is. Some of us have changed our philosophy based on new evidence that's come along, but for the most part, I always tell folks there is no right or wrong. You could do this case, for example, as an immediate placement, or you could do a delayed placement. The end result is probably going to be more or less similar, but there are certain advantages of when you would do an immediate placement versus when you would do a delayed placement. So I think it's important for us to look at that evidence. A deciding factor, a major deciding factor always is whether after extraction you have a buccal plate or not. So a lot of times that makes the decision for you whether you're going to place an immediate implant or just do some socket grafting. Then the question is, if you do place an immediate implant, do you always have to graft? Or can you get away by not grafting? And that again is a little different in the aesthetic zone versus in the posterior areas of the mouth. And we'll talk about that. The other question is, do you make a provisional restoration or not? If it's in the aesthetic zone, obviously it would be nice if we can give our patients at least a tooth to walk out with. But again, will that provisional restoration help these aesthetic cases, or do they actually end up causing some problems down the road? And we look at that. And if we do decide on doing some delayed placement, what type of graft material would you use? I have friends and colleagues that use xenograft. I have other colleagues who use allograft. Some use a combination. Is there one graft material that is better versus the other? So we'll actually look at the evidence, and that'll hopefully help us make a decision. So are there some better guidelines? So that was the question we asked ourselves a few years ago, and that's what led to our publication in 2015 that talks about these guidelines, and I'll share those guidelines with you. So when we look at the evidence, purely from an evidence standpoint, do immediate implants have the same survival rate as delayed placement? And the answer is yes. Immediate implants have very comparable survival rates as delayed implants, almost in the high 90s. So if somebody says immediate implants don't work, they fail, that's not true. If you do them the right way and if your case selection is good, the survival rates are just as good as delayed placement. That's what evidence tells us. We know, and we've known this for a long time, that when you extract a tooth, if you don't place anything in the socket, whether it's a bone graft or an implant, you will lose a lot of that bone volume. So here you can see we lose about 1.2 millimeters of height and about almost close to 4 millimeters or up to 4 millimeters of width if we don't place immediate implants or we don't put something in the socket. With immediate implants, there's still some bone loss. That's just how biology works, but it is reduced. So with grafting or with immediate implant placement, we lose a little less volume of bone. So there seems to be some advantage of seeing that in the right situation, if we could place an immediate implant. Also, the meta-analyses has shown us that immediate implants might be at a higher risk of complications, but then out of the same meta-analyses, we find that the aesthetic outcome might be better when you place immediate implants right after the extraction. So it's really, the evidence tells us we have high survival rates. We know from evidence that we can get better aesthetic outcomes. So as clinicians, how do we make that decision? When is the right situation to place an immediate implant versus when are we better off just delaying placing the implant? We are better off just grafting the site and then come back and placing the implant in a delayed fashion. So the biggest deciding factor, especially in the aesthetic zone, is after you extract the tooth, do you have a type 1 socket? Meaning all the 4 walls of the socket, mainly the buccal plate, whether that buccal plate is present or not. So a type 1 socket is an ideal socket for immediate implant placement. A type 2 socket is actually a very dangerous socket because you still have some good soft tissue, but as you can see, you may have lost some of that buccal plate and not even know it. So it's in these type 2 sockets that we end up seeing more complications and more aesthetic failures down the road. So a type 2 socket is actually not an ideal socket, especially in the aesthetic zone for immediate implant placement. This is better off that we do some grafting, we get some good volume of bone here, and then we come back and place an immediate implant. Now, there are always some exceptions to the rule, and we'll talk about those exceptions as we go along. A type 3 socket is where you have both bone loss and soft tissue loss. So that socket is, it's where a tooth has recession, gum recession, so you know there's no soft tissue, also there is no bone, and those sockets we really need to get some more height of bone and height of soft tissue to get a good aesthetic result. So our publication, what we did is, this was based out of a lot of meta-analyses that we did, and we came up with some clinical guidelines. And these are the guidelines that pretty much most clinicians use today when you place an implant in the aesthetic zone, especially with immediate implants. So one is, we need to be at least 2 millimeters away from the buccal plate in the aesthetic zone when we place an implant. So if a socket doesn't allow you to place your implant at least 2 millimeters away, not 1 millimeter, 2 millimeters. The old rule used to be 1 millimeter, but that's not true anymore. So if you can get that implant to be 2 millimeters from the buccal plate, then an immediate implant would work out well. The other aspects of success are, today we place a slightly narrower implant. When I say narrow, I don't mean mini implants. I mean, instead of placing a 5 millimeter implant for a central incisor, we try and place a 4 millimeter or a 4.1 millimeter implant. So a slightly narrower implant gives you more bone around the implant, especially in the buccal aspect, so less chances of bone dehiscence and soft tissue recession in the future. We place our implant about 1 to 2 millimeters subcrestal. So what that does is that allows to maintain some bone height long term. That's what most of the studies have shown. So a subcrestal placement is always better. Platform switching, whenever available, we know the benefits of platform switching. It medializes your connection. It allows for more bone and soft tissue around the head of the implant. So that's a very important factor. Dual zone grafting. Now this is what I'll get into. And when I talked about should we graft or not graft our immediate implant cases, we know that if you have a small gap between the implant and the buccal bone, that will fill in with bone. Really, you really don't need a bone graft. It is a socket, so it will fill in with bone. But if you want to get good soft tissue height, then this dual zone graft is very important. I'll discuss this in detail with you. And then sometimes in cases with a thin gingival biotype, or today we call it a phenotype, it might be better to delay your provisional. And I'll show you clinical examples of all of these. So let's get into some clinical cases. So we mentioned that type 1 socket is your ideal socket for immediate implant, and you can make a provisional, an implant-supported provisional, if you get good primary stability. So obviously, if your implant goes in tight, you can make the patient a provisional. But let's look at two different scenarios. So one scenario is that you have a type 1 socket in a patient with a thick gingival biotype or a thick gingival phenotype versus a patient with a thin gingival phenotype. So let's look at these individual cases. So let's look at the thick gingival biotype first. So this case will demonstrate an immediate implant placement following some of the guidelines that I mentioned in a patient with a thick gingival phenotype. So what do I mean by thick phenotype? Meaning your thickness of your gingiva is more than 1 to 1.5 millimeters. Anything that's less than that in terms of thickness is a thin gingival phenotype. So here this patient had a hopeless left central incisor that we extracted. And as you can see, that is where the socket is. But if you place your implant right into the socket, you won't get that 2 millimeter distance. So you drill more towards the palatal. The idea is you have to, when you extract the tooth, you preserve the buccal plate, so you make sure it's a type 1 socket. And then you have to come in with this pointer starter drill and engage the palatal bone so that your drilling sequence is more towards the palate and you have at least that 2 millimeter distance from the buccal plate. So here, if you're able to maintain that trajectory, your implant is 2 millimeters away from the buccal plate, and assuming you had about 1 millimeter of that buccal plate already, that gives you a 3 millimeter cushion. And that's a very safe way of placing immediate implants in the aesthetic zone. We need at least 2 to 3 millimeters of that buccal bone, especially in patients with a thin gingival phenotype. Otherwise, you'll see recession a few years later. So we extract, we drill towards the palate, and what you see here is a slightly narrower implant. In the past, I would have placed a 4.7 millimeter implant to fill that socket. Today, I go with a 4.1 or a 3.7 implant just so that I have more bone around the implant and I'm 2 millimeters away from the buccal plate. So one size narrow, we place the implant, we have good primary stability, and in this case, we will make the patient a provisional. But before we do that, we do this dual zone grafting. So this dual zone grafting is you basically pack a lot of bone graft material up to the soft tissue height. And I'll show this, I'll get into this in more detail, but this is mainly geared towards supporting that soft tissue around the neck of the implant. So that graft material is placed, it is sealed. So there was a collagen membrane, a biomen membrane that we placed, and we put some high viscosity tissue glue to seal that, and we'll talk about that as we go along. And then in this case, we made this patient a very quick, not so fancy, cement retained provision. So the margins, so there's no cement being pushed below the gingiva, below the gingival margin. It's it takes 5 minutes to make this non-fancy cement retained provisional. And the idea is that this patient has a thick gingival phenotype, which will fill in on its own. So here we see about 2 weeks later, you see how nicely the gingiva has filled in, the papillas have filled in, and in about 3 to 4 months' time, here we waited about 4 months, you're ready to take your final impression and make the patient a final prosthesis. That's the final prosthesis about 3 years later. And here you see an X-ray about 3 years later. And ever since we started doing this dual zone grafting, we don't see that crestal bone loss. We in fact see bone all the way up against the abutment, against the crown, because of that dual zone grafting. So also here, going one size narrow with the implant, we've allowed for more bone to fill in. So what we did, we followed the same guidelines that I talked about. We placed this implant 2 millimeters away from the buccal plate. We went with one size narrow. We placed the implant about 1 millimeter subcrestal, which again is very important. And then we supported the soft tissue with this dual zone grafting, and we made this patient a cement retained provisional. This is not ideal. A screw retained, as you'll see, is a better provisional, but the trade-off is that this provisional is quick to make. And in a patient with a thick gingival biotype or a phenotype, the provisional really doesn't play that much of a role. That if you've done this dual zone grafting, the soft tissue will fill in nicely. You don't need to mold the soft tissue in a thick biotype situation. Would a screw retained provisional be better? Absolutely, no question about it. But a screw retained provisional is also going to take a lot of chairside time, and there's added costs to that. So again, what did we learn from this case was mainly we were demonstrating that if we follow these guidelines, we are able to see predictable bone and soft tissue fill. And I think the most successful aspect of this was our clinical guidelines based on years of evidence, last 3-4 decades of evidence that have led us to this point where if we follow these clinical guidelines, we can see more predictable results. Now let's look at a more challenging situation. So you still have a patient or a site with a type 1 socket, but this patient has a thin biotype or a thin gingival phenotype. So this case will demonstrate immediate implant placement in a patient with a thin gingival phenotype, option A. So option A is you make this patient a immediate provisional. So this is a case shared by Dr. Dennis Tarnow and Dr. Chu. I've had the good fortune of teaching a lot of courses with them for years. We've worked and taught together at dental schools and lectured throughout. So this is a good case that demonstrates how you would manage a thin phenotype situation. So you have, again, the same tooth number 9 or number 2-1 that's fractured. Tooth is extracted. We make sure it's a type 1 socket, meaning the buccal plate is intact. And again, you use this pointer starter drill and you engage the palatal bone somewhere in the middle third of that palatal shaft. So you engage that palatal bone so that when you place the implant, it doesn't get kicked out towards the fascia. So remember, we have to keep that 2 millimeter distance from the buccal plate. So the implant's placed subcrestal, 2 millimeters away. If one of the things is today, if we were to do this, we would probably go with even one size narrower implant, but here we have about 1.5 to 2 millimeters away from the buccal plate. But in this case, Dr. Chu, Steve, decided to make a beautiful screw retained provisional. So you can see this dual zone grafting. It's bone grafting all the way up to the height of the gingiva. And then a screw retained provisional is fabricated, and this is how the patient leaves. So out of occlusion, and you can see some bone graft particles here. That's fine. You'll have these bone graft particles coming out of the gingival sulcus, but the idea of these graft particles is to support the soft tissue. And you always want to make sure that your provisional is concave right there, so it doesn't put too much pressure on that gingival margin on the fascia. So this is the before, and then this is 8 months later with the final restoration. And you can see beautiful, healthy gingiva and good stippling. So in a thin gingival phenotype situation, if you're going to place an immediate implant, you can go with option A, where you make a screw retained provisional, because here you have to make that provisional just as good as the final crown, so that you're able to maintain the height of the papilla and you're able to maintain the height of the gingival margin. So this is option A. And again, same guidelines that we talked about. 2 millimeters away from the buccal plate. In this case, if we were to do this today, like I said, we would probably go a little bit narrower, one size narrower, but everything else remains the same. And these screw retained provisionals, they are ideal, but long-term cases, what Dr. Chu has shown and also Joe Kahn has shown is that these thin phenotype cases are at a high risk of developing recession a few years later. So I always joke and say, you know, the most successful implantologist is the one who keeps moving every 2 to 3 years. So that, you know, you never see your failures, but if you practice in one location long enough, you will see some of these cases. And I'll show you examples of these as we go along. So, but nevertheless, this is option A in someone with high aesthetic demands and doesn't want to go or wear a removable prosthesis. This option A is a good option. Now, like I mentioned, this is what I did in this case many, many years ago. This is one of my failures. I think it's important to show some of your failures and how you managed it, because that's how we learn. We learn from our failures. We don't learn from our success. Success makes us feel good, but failures is when you really learn. So I did an immediate provisional with exactly everything, but only thing was years ago, we never used to place our implant 2 millimeters away from the buccal plate. We thought 1 millimeter is enough. So I think that contributed, plus I did not manage the phenotype. The implant's osseointegrated, but as you can see, there is soft tissue dehiscence. And this patient is still in a provisional because he lost his job and, you know, could not afford a final restoration. So here's another example. This was done by a colleague of mine, and as you can see, thin phenotype, again, very high risk for recession down the road. Same thing here in this case as well. So these thin phenotype cases, you can make a provisional, but we have the opportunity of actually converting that thin phenotype into a thick phenotype if we don't make an immediate provisional. And I'll show you examples of what we can do with that. So how did we fix this? We actually did a free gingival graft. So free gingival graft is not very aesthetic. It looks like a tire patch, but this is something that I'm doing so regularly in my practice now for implants placed by a lot of my colleagues in this area, where now you have recession. You won't be able to cover the threads of the implant with bone if the implant is sticking out of the housing of bone, but a free gingival graft can get you a lot of attached and nice thick gingiva. And in patients with a low smile line, you do a free gingival graft and you have that much keratinized gingiva, they will not lose any more soft tissue for a long time. Here, for example, you can see there's some soft tissue dehiscence. And this, of course, was done by another clinician many years ago. And, that time the idea was, if you're placing an immediate implant, you go with a big fat implant to fill the socket. Well, the implant is integrated, but there's no buccal bone, as you can see. So with a fat implant like this sticking out of the housing of bone, you won't be able to grow bone on an implant surface. The only way you can grow that is if you still have a socket around it, or your adjacent bone height buccally is a little bit higher so that you have some reservoir to grow and pack that bone. So in this situation, we cleaned the implant and we did a connective tissue graft to build up some nice thick gingival phenotype, and that's about a year later. And we followed this gentleman now for close to 5 years, and the site has been stable. So it's a rescue procedure, but all of this can be avoided today if we follow our guidelines. So let's look at this next case, and this case will demonstrate immediate implant in a patient with a thin phenotype like what you saw, but with option B. Option B is you don't place an immediate provisional. You do an immediate placement and you do a bone graft and you cover the implant to get some more attached gingiva. So here, again, it's the same tooth number 9, as we've seen in some of the previous cases, or tooth number 2-1 based on the FTI system. So again, we extract, we make sure it's a type 1 socket, implant is placed 2 millimeters away from the buccal plate. In this case, this was 2 millimeters subcrestal, 1 to 2 is ideal. And then we will do some dual zone grafting. And my graft of choice is Puros allograft. It's cortico. I like to use sometimes just cancellous, but if I'm doing this dual zone grafting, I will use a combination, cortico-cancellous, so it comes already pre-mixed. And we use these titanium packers to pack this bone graft, and we pack and bury that implant over the cover screw of the implant all the way up to the height of the interdental papillae. So this is dual zone grafting. You're grafting not just the bone zone, but also the soft tissue zone. And idea is to support the soft tissue. It's not so much to grow bone on top of the implant, which you actually do, as you will see. But if you are able to maintain that soft tissue height, you'll gain some more keratinized gingiva on the occlusal aspect. And we have our collagen membrane, sutured, and then this purple stuff that you see, this is periacryl, this is high viscosity. So this is cyanoacrylate tissue glue, but this is the high viscosity. It comes in a gel form. So you just paint it on, let it dry, rinse, and then do a second layer of this. So what do we see? This is all this graft material. This was the dual zone up to the height of the soft tissue. This is what you see in about 4 months. So 4 months, hopefully the implant's osseointegrated. We go in, we do our torque test, and you still see some bone graft particles in the soft tissue, but the idea is it's given you a large volume of keratinized gingiva. So everything on the occlusal aspect is attached gingiva. So you can make an incision towards the palate. You can use a tissue punch if you have enough soft tissue on the facial, and you have extra soft tissue, and this is thick gingival phenotype. So we've converted, as you can see, if you compare the adjacent number 8 with this, we have so much thicker gum tissue, so much thicker gingiva because of this dual zone grafting. And then this is the provisional. You can let the provisional sit And sometimes it takes a few weeks. In some patients, it can take up to 6 to 9 months for that soft tissue papilla to fill in, and then you can make this patient a final restoration. Here's another example of this option B. So as you can see, we have placed the implant following the same guidelines: immediate placement, 1 millimeter subcrestal, 2 millimeters away from the buccal plate. Sometimes in this case, it's probably 2.5, close to 3 millimeters, which is good as long as it doesn't compromise your ideal position for the implant. And then we will do this dual zone grafting. So we are using this corticocancellous bone all the way up to the height of the soft tissue. We use a collagen membrane. I will use the 3 membranes that I use in my practice. I use BioMend a lot. I use Copios, that's pericardium membrane, and then I use OsseoGuard. And again, I can get into the Q&A, but all 3 of them more or less do the same. They're resorbable membranes. They are very kind to the soft tissue. So here we suture this. That's what it looks like in a radiograph. We let this heal for about 4 months, ideally. And at 4 months, like I said, you could do a palatal incision. And that's what a good friend of mine, Dr. Sonic, published a few years ago. It's something we've been doing for over 20 years. He just hadn't published this. But instead of, if you need more attached gingiva or you need more soft tissue height, when you expose that implant 4 months later, instead of doing this tissue punch, you can make your incision towards the palatal, and all of this nice attached gingiva that you have on the occlusal, you can push it to the fascial. And then whether you put a healing abutment or you make a provisional right away, you have all this extra soft tissue height and extra thickness of soft tissue. So by delaying the provisional, you have the ability to convert a thin phenotype situation into a thick phenotype situation, which in my opinion, unless a patient is very demanding and they want a provisional on the implant right away, this is a safer and a more sure way of guaranteeing that you will have a thicker phenotype around that implant many years later. So that's what we did here. So as you can see, 4 months later, you still see some bone. And a lot of times I have to actually remove some bone that grew on top of the implant. But look at how beautiful this gingival looks. We have such thick gingival phenotype here. And this is the before, and this is the after, where you have actually gained. And we've actually done a whole case series where you can gain 3 to 4 millimeters of soft tissue height by doing this, this guided gingival growth, meaning you bury the implant, let some soft tissue grow over the implant, and then push some of that towards the fascia. So, same guidelines. The only difference is we delay making the provisional till 4 months later. And sometimes some of my colleagues and patients with a low smile line, you can go straight to your final restoration because you have so much thick tissue. That thick tissue will fill in very nicely because, as I showed you in the first case, thick gingival phenotype or biotype is very predictable. The papilla fill in, you just have to give it some time. So this option B is where you delay making your provisional restoration. So now let's get into 2 implants, adjacent implants in the aesthetic zone. And this is where things get even more demanding because, we followed that 3 millimeter rule that if you maintain 3 millimeter distance between 2 implants in the aesthetic zone, you won't lose bone. But in terms of soft tissue, it's very unpredictable if you have a patient with a thin phenotype. So here, for example, these two premolars, same clinician, same implant, everything's done the same way. In a premolar, 3 millimeters between two implants is adequate because you have so much more width of bone in the posterior that the papilla fills in between these two implants and it looks good. Whereas same implant system, same clinician, two implants in the aesthetic zone, you don't have that much bone volume, but even if you keep 3 millimeters, sometimes that's not enough. So when we published, we also gave some revised guidelines. And this is a good case that shows you over the years, good placement by a colleague of mine, is an excellent surgeon, good placement, good restoration, good hygiene. We have the 3 millimeter distance between the two implants, but this patient just kept losing soft tissue. And these crowns were redone, and this has been redone 3 times, and you can see how unaesthetic this looks. So the 3 millimeter rule is good everywhere else in the mouth, but not in the aesthetic zone. This in the canine to canine in the aesthetic zone, there just isn't enough buccolingual width of bone that you need a little bit more. 3 millimeters sometimes might work and other times. So if a patient has a thick phenotype, I'm okay with minimum 3 millimeters. If I can get more, I always try for that. But if somebody has a thin phenotype, that my whole approach is different. And let me share how that's different. So the other option really is that if you cannot get that 3 millimeter, then you're better off making a cantilever. So we extract these teeth and we place an immediate implant, same guidelines. If we just had about 3 millimeters distance, so we decided not to. Could we have been okay? Yes. Chances are probably we could have, but at that time, the clinical decision in some high-risk cases is if you cannot get more than 3 millimeters between two adjacent implants, you're better off just doing one with a cantilever. But we did some dual zone grafting, and you can see how much more thick soft tissue we have. And here, at the time of exposure, 4 months later, we did a palatal incision and we pushed all of that nice, thick, soft tissue towards the facial. As you can see, we have so much more height. This is the cantilever. And then this is about a year later, and this is 3 years later, post-restorative, where there is good height that's been maintained. So a cantilever is an option if you cannot get two implants more than 3 millimeters, or at least minimum 3 millimeters if you have a thick biotype. So when we started looking at a lot of these aesthetic cases, we found that the most predictable in not losing the papilla and not developing recession with two adjacent implants in the aesthetic zone was actually a distance of 5 millimeters, not 3. Now the question is, you may not have 5 millimeters. So that is something you have to keep in mind. But what it does is it changed how I practice. So if I have a patient with a thin phenotype and they need two implants, my approach is to do some dual zone grafting, get some nice thick soft tissue. I'm thinking that, instead of big fat implants, I'm going one size narrow. That gives me a little bit more room. And even if I can't get 3 millimeters, if I can get 3.5 or 4, it's still better and more predictable than just 3 millimeters. So this is how we approach it today. So this case will demonstrate immediate implant in the aesthetic zone and adjacent sites with a provisional restoration. So with a provisional restoration, the only time we do that with two adjacent implants is if the patient has a thick phenotype. So this is done by Mike Sonic. You can see this patient is losing both central incisors. This patient has a thick gingival phenotype. But look at the implant placement. They are 5 millimeters apart. They are about almost 2.5, 3 millimeters away from the buccal plate. There is a good enough socket to pack bone all the way up to the height of the soft tissue. And since this patient has a thick phenotype and we had enough distance from the buccal plate, we made immediate provisionals. Out of occlusion, but beautiful screw-retained provisionals. And you can see within 4 weeks how nicely that tissue fills in. Even between 8 and 9, where there was a big, a black triangle, there was no papilla, you can see how nicely that papilla has filled in. This is before, this is final restoration 4 months later. So thick biotype, I think the critical aspect is that you can make a provisional if you get good stability for your implant, or you don't have to. I mean, if your patient's happy with a Essex or a flipper, that's fine too. But a thick biotype is very forgiving. But the key thing is same guidelines as single implant placement, 2 millimeters away from the buccal plate, 1 millimeter subcrestal. Do this dual zone grafting, which is very, very important. So same guidelines, but this screw retained provisional if you have this thick gingival biotype. The important thing is this inter-implant distance here. Always try to get more than 3 if you can. That just makes it very predictable, where there's less chances of you losing or the patient losing that soft tissue between the 2 implants. Long term. So here's another case. This will demonstrate same thing, adjacent implant placement, but with a delayed provisional. So this patient had a thin phenotype, and we wanted to gain some extra thick soft tissue on the facial aspect. So as you can see, these 2 central incisors are extracted, type 1 socket. Previously, that's what I would have placed. I would have placed a 4.7 millimeter implant right into the socket to grab the socket, get good stability. But today, no, we go one size narrow and we position our implant keeping in mind that 2 millimeter distance. Now, a lot of us were doing this palatal placement, but the beauty of evidence is when you put a number to it, you quantify it, it's always there in your mind. So that's how, as dentists, those numbers make sense. They help guide what we do. Same thing whether it's restorative dentistry, whether it's surgery, whether we're looking at contact points, etc. These numbers help quantify and help drive our decision. So as you can see, that's where those implants were placed. Instead of 4.7, these are 4.1 millimeter implants. A little bit narrow, gives us more room. And here, because we are trying to get additional soft tissue thickness, we do our dual zone grafting, and we make the patient an Essex. So this provisional is a retainer. It's an Essex retainer, and everything underneath is, like you saw in all the other cases, is grafted membrane. And then we let this heal. About 4 months later, we'll make provisionals at that time. And you can see you have such nice, thick, soft tissue here. And depending on how much you need, sometimes I'll make an incision, push some extra soft tissue. Other times, if I have, like you saw, the sockets were pretty wide, buccopalatally, I'll just do a little tissue punch towards the palate, and I'll just push all of this soft tissue onto the fascia. Nice, thick, and then you leave these provisionals for however long you want, and then when it's ready, you can make this patient a final restoration. So same guidelines, except we delayed making the provisionals. So that becomes more of a judgment call. Making provisionals, there's a lot of time that's spent chairside. There's a lot of expense. So you pick and choose in which cases you would like to do your provisionals. And others, you can make them a removable provisional, such as an Essex retainer or a flipper. I prefer Essex, not a flipper, because a flipper puts a lot of pressure on the bone graft, on the occlusal. An Essex is a better option. Now, this dual zone grafting that I've talked about, if you have a type 2 or a type 3 socket where there's buccal bone loss, and in type 3 there's soft tissue loss as well, then we are not placing an immediate implant, in the aesthetic zone at least. It's too risky. So here we just do grafting. And this is a classic study by John Iasella, who was a student of mine. And what they showed is that when we do grafting, not only do we maintain the buccolingual width, but actually grafting, if you've done grafting properly, you increase the vertical height by almost 1.5 millimeters versus just the extraction alone, where you lose about 1 millimeter. So the difference between grafting properly is you can gain about 1.5 to 2 millimeters of height of not just bone but soft tissue, which is huge. In our world, in the aesthetic zone, 1 millimeter is a mile, so 2.5 millimeters extra is huge. And I just wanted to show you some examples of that. So this dual zone grafting, which started off around immediate implants to support the soft tissue, we then went on, and today we do this for all our socket grafting cases. And the dual zone basically means you're not just grafting up to the bone zone, you're grafting up to the soft tissue zone. So what it does is, in the aesthetic zone, your interdental bone is always higher than your facial bone or your palatal bone. So think of it this way. In the past, we never even tried to jump higher. We would just settle. And, but anytime we were able to maintain our bone graft in the occlusal aspect, this is what we got. So here we grafted. We were not even trying dual zone grafting, but if our bone graft stayed on the occlusal aspect, this is 4 months later, not only did we get so much width of bone, we gained that much height. So this was a hit or a miss. Some cases we got such beautiful results, other cases we did not. And the reason for that is that in the past we extracted, we did socket grafting, and we put our membrane, but we never overbuilt up to the height of the soft tissue. And mainly it was because we knew that if we try to pack bone all the way to the top, it'll get washed away. The membrane will get washed away, the bone will get washed away, and that's why we never did. But today, we intentionally pack and we condense. I'll show you bone condensers that we use to pack this bone up to the height of the soft tissue, and then we seal it. We seal it with collagen membrane, we seal it with tissue glue, so that we are able to prevent that washout effect. And then suddenly we started seeing better height, not just soft tissue, but also bone. So here's an example. This case will demonstrate a trauma case where there's no buccal plate, and you'll see the amount of bone loss. But I just want to show you that today, and this was a case we did a few years ago, that today with this dual zone grafting concept, how much bone height we can gain. So because of trauma, you can see that left central incisor is almost extruded. When you take a scan, you see there's only one fibroblast holding this root in place. Literally, it's just the soft tissue holding this tooth. The whole tooth is out. There's no buccal plate whatsoever. This is a severe defect. So we extract the tooth. You can see the fracture. But here, we are going to graft and overpack And it's all particulate, no growth factors. And, I lectured a few months ago on bone grafting in the aesthetic zone, and I showed a lot of cases with particulate graft. It's just, you have to get comfortable using particulate graft. And if you condense it, you overpack the defect, you secure it with a BioMend extend membrane, you secure it, look what happens. So that is the graft in place right away. This is soft tissue. About 4 weeks later, you can see, because of supporting overpacking up to the height, look at how much extra soft tissue is growing here now. You can see we have good width. That was the before, and this is 6.3 meters of additional bone. This is huge. So much extra just with particulate, because you secure this graft material in place. And just to show you, I had to remove more than 4 millimeters of bone to get that implant in. And you can see that even with the provisional, there is so much extra soft tissue that my referring dentist had and could play with. But this just shows you how much bone we had to remove to get that implant at the correct height. Here's another example, very similar, that demonstrates this dual zone grafting. So this is a young lady. She fractured this right central incisor, thin phenotype, and here in the scan, you can see we've lost about 60 to 70% of that buccal bone and about 30% of that palatal bone. But the good thing, if you look at the x-rays, she still has good interdental bone height. So we do our dual zone grafting, and I like to use this Puros corticocancellous bone. I will pack it. I will use these bone condensers, as you can see, to pack this graft material. I do it in layers, all the way up to the height of soft tissue. Membrane goes in, graft goes in, close the membrane, and this is sealed, sutured, and secured with that periacral tissue glue. And you can see, look at the width. Particulate grafts, if you want particulate grafts to work, you have to use these heavy-duty bone condensers. You have to condense this particulate graft. Ever since we started doing it, we use almost 30 to 40% extra graft material. That's the only way, because these will shrink. So you have to overbuild. And this is 4 months later. You can see we have gained soft tissue height. 4 months, no buccal plate, no lingual plate. We put the implant in. The bone at the top is still maturing. So as the implant is osseointegrating, that bone is maturing. This was a quick, non-fancy provisional that was done. And then here is the final restoration. And you can see that same bone all the way up to the height of the crown, or up to the height of the abutment. So that's what this dual zone grafting is able to do. Because of time, I don't want to, I couldn't share a lot of these dual zone cases, but I did that a few months ago, and maybe I'll have the opportunity to show bone grafting in the aesthetic zone, where we've been able to do amazing in terms of growing height and width just with particulate material. Now, in terms of choice of graft materials, some people use xenograft. When we look at the evidence, we see there's no difference in bone height, whether you use something like Regeneros or BioOs versus an allograft such as Puros, but there's certainly more vital bone in an allograft. We know that. When we look at more recent evidence in sinuses, we find there's really no difference in sinuses, but implant survival was the only criteria. And wherever there is large bone volume, such as posterior sockets or sinuses, there's really not that much difference in bone volume or survival rates of implants. But in the aesthetic zone, our demands are very different. We want more vital bone so you don't end up with just losing some bone or those xenograft particles working their way out through soft tissue. So in sockets and ridge augmentation, when we compare xenografts to allografts, there's no difference statistically, although allografts always give better height. And to me, that is huge. In aesthetic, you grow some height of bone, that soft tissue grows with it. So allografts is my preferred graft material when I'm grafting in the aesthetic zone. And just to show this one case real, as you can see, this patient literally has maybe 2 fibroblasts holding this tooth in place. No buccal bone, no lingual bone. The CT scan shows nothing, but we have some interdental height of bone. So this was only puros corticocancellous, and 4 months later we had a solid block of bleeding bone where we could put an implant in. So in my hands, allografts in these severe cases with this dual zone grafting concept work really well. So let's look at this case in a type 2 socket from start to finish. So hopeless tooth, we extract the tooth. As you can see, the buccal plate is missing. That's what this instrument is showing, this curette. So there's no immediate implant that's going to be placed, but we'll do some socket grafting. Here I use some Biomend Extend and push this all the way up to the base of the socket. Then I use corticocancellous, puros corticocancellous with these bone condensers, and look at the buccal lingual width. We rarely condense. We condense, we pack, and we overbuild up to the height of the soft tissue. Look at how much volume of graft material there is. And then it's secured. We paint periacral. That's how much height. We've overpacked. You do that. This is what it looks like in 2 weeks. And look at all that extra soft tissue, keratinized gingiva that we've been able to grow vertically in about 4 months. And then we, in fact, grew bone where I had to remove almost 3 millimeters of bone to get that implant at the right depth. That's restored. You can see that same phenomena of bone just right up against the abutment or that crown. And then this is about close to 3.5 years later, where you can see beautiful soft tissue. In fact, this patient is starting to develop some recession on the natural tooth, but here where we place the implant, because we overbuilt and we converted by building bone, we had extra soft tissue, so we converted this site into a thick gingival phenotype. You can see it remains stable for many years later. So again, allograft versus xenograft, and this is very recent. Similar volumes, so when you take an X-ray, radiographically, clinically, you see similar volumes, but the drawback is it's not an apples to apples comparison, meaning most studies do not discuss the shape of the defect, the location of the defect, and only implant survival is evaluated. So when you start looking at implant success, aesthetic success, our demands today are very high. So if using an allograft gives me that extra height and extra soft tissue height with it, that's huge. So real quickly, just in the next 5 minutes, I'll wrap this up, but the same guidelines apply in the posterior. Posterior, you actually have a bigger socket, so you have more of a cushion, but we again follow very similar guidelines as we do in the aesthetic. And I'll just go through these cases very quickly. So for example, mandibular molar, we'll extract, make sure it's a type 1 socket. Sometimes even in a slight type 2 socket in the posterior non-aesthetic area, I'll still place an immediate implant. So that's the only exception in the posterior. But we use the same pointer starter drill to engage the interdental bone. We drill to a final drill. Implant is placed. I always try and place at least 1 millimeter subcrestal. That way you preserve that crestal bone. That's what evidence has shown us. And then, again, you can, depending in the posterior, my protocol is I'll always graft, but if your gap isn't too big, too wide, meaning if it's less than 1.5, maybe you can get away without grafting. Because it's not an aesthetic, we're not trying to gain as much soft tissue. But in my practice, I graft all the time. So these cases, these next few cases will just highlight immediate implant placement in the posterior area, both in the mandible and the maxilla. So fractured tooth, extracted, drill right into that interradicular bone. And again, you have to get that primary stability. So here in the past, we used to use those big fat implants, 6 millimeters or greater in width. Again, we have become a little bit more conservative. We realize that, bone will remodel and you might end up losing some of that buccal plate long term. So maybe just going one size. So instead of a 8 millimeter implant, I'll place a 6 here. Implants placed, grafted as we would, and then this is the final restoration. This is about 5 years later. Same concept here. Drill right into the interradicular bone, place the implant, final restoration. So again, I've been doing posterior implants, like I said, for about 25 years, and we've had the same success rate as we do with delayed implant placement. This was an interesting situation. This was a gentleman who was 95 years old, and he had teeth. It wasn't that he had dentures and he just was going to lose this first molar. As you can see, he still has a complement of teeth. So my first question was, why? Why do you even want this replaced? You have good other teeth to chew on. And he said, why not? The only medication he was taking was aspirin, a baby aspirin, healthy. He drove himself. He said, my father lived to be 110, so I want to enjoy. I said, look, it's going to be very expensive, etc. He said, what else am I going to do with my money? So this was amazing. And this is now he's, last time we saw in his practice, he was 99. So we placed an trabecular metal implant. These are again Zimmer. They're made out of trabecular metal, tantalum, and the whole idea was so that we could load this implant right away. And sometimes we wait maybe a few weeks. So this is about 1 year post-loading. Here, this gentleman was actually going to start chemotherapy for prostate cancer, and the concern was, his chewing efficacy, so we wanted to give him function, but same principles, even if it's the anterior or the posterior. Here we place trabecular metal implants, 1 millimeter subcrestal, same guidelines, away from the buccal plate, and then we grafted, as you can see here, and we let the soft tissue heal for about 6 weeks, and he got final restorations 6 weeks later. And then this is 5 years post-loading. So to wrap things up, decision. This is in our publication as well. So a type 1 socket is your ideal socket for immediate implant placement. If you run into a type 2 or a type 3, especially in the aesthetic zone, we do not place immediate implants. Like I said, I'll maybe cheat a little bit in the posterior, but never in the aesthetic zone. Here, you're better off doing just bone grafting. I like to do the dual zone grafting. I like to get some extra height of bone, mainly so that I can get some extra soft tissue height with that. But if it's a type 1 socket, that's your ideal socket. If the patient has a thick gingival phenotype or biotype, that's easy. You place the implant like all the guidelines, 2 millimeters away from the buccal plate, 1 millimeter subcrestal. I'll do some grafting. And if you want to make a provisional, you make a provisional. Whatever you want to do, whatever your comfort zone is, you cannot go wrong with a thick phenotype. It's very forgiving. With a thin phenotype, that's really where you have to use your clinical judgment. If you want to make a provisional on that immediate implant, then it has to be a screw retained. We still, recommend dual zone grafting in those cases. Or today, I tend to do more delayed provisional. So I'll do immediate placement. I'll pack bone like you saw on top of the implant, bury that implant, and then I have extra soft tissue to play with 3 to 4 months later. And at that time, you can make your provisional in highly aesthetic cases, or if patients have a low smile line, you can even go straight. You expose the implant, put a healing abutment like an encode abutment, and then you make a final restoration. So this decision tree that we had published, this pretty much has served us well in the last 4 to 5 years. So with that, I would like to thank all of you and for taking time away from your families. I hope everybody in wherever you might be in different parts of the world, you're staying safe and you and your family are healthy. I wish you all the best. And thank you, Zimmer Biomet, for this opportunity again. And I am open for some questions.
Dr. Bola, wow, what an excellent presentation. Your clinical experience and your clinical perspective for treating patients with immediate implant placement, with and without grafting, really gave all of us a lot of great information, new information too, clinical pearls. And we love that you shared your decision-making factors with all of us. We have quite a few questions. Let's go ahead and get started. The first question was, it came in pretty early on, and you may have talked about it again in one of your dual zone grafting cases, but what was the painted material after the dual zone graft on the thin phenotype case? Was it a collagen something?
So we, all the grafting cases have after the bone graft, we put a collagen barrier, such as Biomend or OsseoGuard, and suture it. And then on top of that, I paint a cyanoacrylate tissue glue. So the name of the product is periacryl HV, high viscosity. So there's a company by the name of Glue Stitch that makes it. It's cyanoacrylate, it's tissue glue, but it's in a gel form, so it doesn't run. You can paint it very nicely on top of the membrane and the soft tissue. So it just acts like a dressing, if you would, to protect that collagen barrier.
Okay, excellent. Someone said you may have covered this because they arrived a bit late, but what material are you using for your dual zone grafts?
So I strictly use Puros corticocancellous bone. So it comes pre-mixed. Zimmer Biomet, sells that. It's cortical bone and cancellous bone. It's pre-mixed. So I try to keep things simple in my practice. So that's my go-to graft material for pretty much 90% of my cases. So, and the most important thing with particulate grafts, and I cannot stress this enough, is to use bone condensers to really pack and overpack the graft material because it will shrink. So we want to make sure we condense and we overbuild to account for that shrinkage. And that's how we've been able to get, I never used to get these kind of results many years ago. So, it's with clinical practice, you get better at what you do, little tips and little pearls. So that was one of the big, huge pearl was to use these bone condensers to overpack. And by the way, all those cases where we've been able to grow height of bone, there were no growth factors used. So these are relatively, we're not adding extra materials, extra costs. to our patients. These are, like I said, I try to keep things simple, but I think it's just understanding how these materials behave, understanding biology with these defects and managing these defects better is what's led to, more predictable results. And then in terms of graft material, I've used all different kinds of graft materials, and I've used Puros for over 13 years now, and I would say majority of the clinicians will agree with me that it's the best allograft material that's available out there, and that just has to do with the tutoplast process, where it doesn't denature a lot of the proteins in the graft. So my material of choice for dual zone grafting, for ridge augmentation, anytime I'm using particulate graft, is Puros corticocancellous.
Okay, excellent. What instrument do you use to remove the overgrown bone?
So that I typically will use, just carbide burrs. I know Zimmer Biomet just introduced some bone trephines. Like they are basically, just for this reason, if you have bone growing over your implant, these are profile drills that you can use. In fact, we just ordered some last week to try. But so far, I'll just use a regular round carbide.
Okay. When you address the issue of you using the glue, etc., this may have answered this, but let me ask you again in case you have another pearl. This participant asked, when placing an immediate molar implant, how do you close the site without losing the membrane due to the size of the extraction socket? They've had issues with keeping the membrane in place regardless of how well they sutured.
Right. So that is really where, one clinical pearl that I can say is that, I always use a large. What I've found is that when you use these prefabricated sizes, like a 15 by 20, for example, that will work really well in a anterior site or maybe a premolar site, but it's really not enough. You want at least 3 to 4 millimeters of your membrane to go underneath the gingival margin on either side, meaning on the buccal side and the lingual side. So I always will use a larger membrane. I'll cut it myself so that I have some extra that I can tuck in. So that's one way to prevent that membrane from coming out. Other ways, I think this tissue glue helps a lot. So once you suture the membrane, you add another barrier, so that delays that washout effect. But I think the key thing is the type of suture material. I use a lot of Vicryl, but I was having the same experience where you lose the membrane. So using a longer membrane, making sure you have at least 3 or 4 millimeters. And then now I use a lot of PTFE sutures. So these PTFE, they're non-resorbable, but they have some elasticity, and they tend to hold their tensile strength for a little bit longer than silk or Vicryl sutures.
Okay, excellent. We're doing a new program of creating clinical tips. So I'm going to be coming back to you to record that as a clinical tip, Dr. Bola. That was excellent.
Oh, my pleasure. Absolutely.
The next question is, do you prefer trabecular metal implants for posterior implants or only for immediate molar placement?
So that's a great question. I've done over, maybe close to anywhere from 400 to 500 trabecular metal implants over the last 6-7 years. Initially, today I restrict just because of cost. It is a more expensive implant. So I tend to use it more in type 4 bone. So wherever the bone quality, which ends up being posterior maxilla. So I tend to use it more there, or sometimes I'll use it in the premolar area. I tend not to use it as much in the mandible today because, again, the bone is very dense, and I think I can get the same level of early loading with the TSB implant. So, a few weeks is probably not that critical. But certainly in the aesthetic zone, premolar in the maxilla, posterior where the bone quality is poor, I see a huge advantage. And mainly this is my go-to implant if a previous implant has failed. If someone's had implant failures in a site where the bone quality was poor, this gives us that edge. So I still use my workhorse implant as the is the TSV implant that I do 95% of my cases with, and then I think the other for revision cases where either I had to remove an implant because of peri-implantitis, I'll place a trabecular metal or posterior maxilla with the sinus. A lot of times I'll do the sinus grafting and use this. So that's mainly where I use this trabecular metal implant in my practice.
Okay, well, we love it that you're using all Zimmer Biomet products. So wonderful. What are your post-operative instructions when you're doing immediate provisional restoration placement?
Yeah, so obviously the big one is, we tell the patient that, look, this is purely for aesthetics. It's not for function. We make sure that the provisional is out of occlusion. A lot of times we'll make the patient a bite guard as well. And just making them highly aware that, just because you have a good looking tooth doesn't mean you just, go out and bite into something hard. So we just tell them that still no biting into anything for about at least 3 months. We keep reminding them, we give them written instructions also, mainly to not, use that tooth for any kind of function other than it's there purely for cosmetic reasons. So that's the big one.
Okay, excellent. Who makes the bone packers, both the titanium and the second ones that you showed?
So the ones that we use, most of these I've purchased from 2 companies. Salvin is one of them. And the other company is called Duwell. D as in David, O-W-E-L-L, Duwell. They make some very nice instruments. And a lot of my surgical instruments like luxators for extraction, some of the sinus instruments, and even some of the Castro needle holders I get from Duwell. So you can get your bone packers and the titanium instruments from these 2 companies.
Okay. How soon can you place an implant after you do socket preservation?
I like to wait 4 months. We've tried 3 months. I think, you cannot push Mother Nature. Biology has to take that 1.5 sigma bone turnover cycle. So I feel pretty confident that, at 4 months, regardless whether it's the mandible or the maxilla, that the graft material at 4 months, it's still not mature, but it's mature enough where, we've done studies where we did histomorphometric analysis, and we found that there is about 27 to 30% vital bone, and that it's mature enough or hard enough at about 4 months for us to place an implant. And the idea is, if you can wait longer, 6, 9, we used to wait 9 months to a year, and we had solid, bone. Now it's solid enough where if we place an implant, as the bone is maturing, the implant is osseointegrating. So that's been a good time frame in my practice, where 3 months is too early, 4 months is just right, 6 months is better, but at 4 months I feel comfortable that I can place an implant, and then I wait another 3 or 4 months for that implant to osseointegrate.
Okay, I have been asking you these rapid fire questions and not being, I've been remiss about not telling you how many wonderful compliments you keep getting, Dr. Bola. So this one says, great lecture, and I would like to know if you're using some kind of antibiotic mixed with the grafted bone.
That's a great question. So no, and my request is, please, if you want to use an antibiotic, first of all, there is no evidence, scientific evidence, that mixing antibiotics with your graft material will give you better results or will prevent infection. It's one of those things, it's like some people do it because it just makes common sense. It cannot hurt. So in terms of science, we don't have any concrete evidence that it is beneficial. The other thing you have to be careful about is that if you use antibiotics, just use IV, liquid antibiotics to mix with your graft. Because if you take antibiotic powder out of a capsule, it has a lot of cellulose in it. And I've had colleagues of mine where the whole graft material mixed with this antibiotic powder, the cellulose actually caused a physical barrier and prevented angiogenesis, prevented blood vessels from growing in. So the whole graft was just sitting there non-integrated. So I don't use antibiotics. If you use, I don't think there's any harm unless you're using powder. So if you want to use liquid antibiotics, but really, we give our patients a loading dose before we do our surgery. That from science is huge. Giving them a loading dose, 2 grams of amoxicillin an hour before your surgical procedure, and then follow it up depending on what procedure you do. We know from Esposito's meta-analyses over the years that it really reduces infection and early implant failure.
Okay, wow, that is an excellent tip, and the information you shared with us. I'm going to ask just one more question, even though it's still going and going, but because we're going to run out of time and we need to wrap up. So some believe that 0.5 cc's of bone graft is sufficient per socket. Is that true?
0.5 cc is good for anterior sockets, but the cases that I have purely a perio and implant practice, so I always get the more challenging cases. Most of these, even the anterior sites, have a huge big cyst at the end of the root. So I'm always adding more, but typically if it's a central incisor to lateral, maybe some canines, half cc is enough, but anywhere posterior, half cc is not enough. And a lot also depends if you had a big periapical lesion, then a lot of times I'm using 0.75 or 1 cc to really pack bone in and overbuild. But for anteriors, for the most part, half cc should be good enough.
Okay, excellent. Stay with us for just a moment. I want to do a little bit of wrap-up information. I'll be right back to you, Dr. Bola. To take the quiz and obtain 1 CE credit for your participation in this program, please click on the link in the confirmation email you received upon registering for this program. If you have any questions following this broadcast, please contact us at webcasts@zimmerbiomet.com. For a complete schedule of education programs hosted by Zimmer Biomet Institute, as well as the schedule of complimentary live and on-demand web-based programs, please visit our website, zimmerbiometdental.com/education, or download the Zimmer Biomet Education app. This is the very best way to stay up to date on all of the Zimmer Biomet Institute educational opportunities. It can be found on the Apple App Store and in Google Play. Thank you all for joining us.